Okay, Assalamu alaikum wa rahmatullah. Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Walid, for this very nice presentation. Let me, okay. This topic is really very important and interesting for everybody working in ICU. As we know, heart failure can be managed by many specialties. So you as intensivist or anesthesiologist, ER physicians, internal medicine, cardiologists, of course. So heart failure, when the heart fails, it can fail anywhere in the ward, in the OR, in ER, in ICU, at home. But there is a universal definition for heart failure, which is, as I mentioned, universal. So you're gonna see this definition everywhere, regardless of the guidelines you see or the review anybody is doing. Is going to be, at the end of the day, the heart is defined to be failing or failed when you have a clinical syndrome of a context or constellation of signs and symptoms of congestion and low cardiac output or hypoperfusion due to structural and or functional cardiac damage that, as I mentioned, results in or results from a low cardiac output state and or increase intracardiac filling pressures of both atria, both ventricles, right and left. But at the end, as I mentioned, the heart will be defined as failing. And the patients, regardless of the heart failure, would present with certain signs and symptoms. Also universally, and it doesn't matter whom you are talking about heart failure or dealing with heart failure, you're gonna end by having your patient with heart failure in one of two types. Either the heart fail because of the systolic function is not enough to maintain and to keep coping with the body need of blood pumped to every single tissue or cell in the body. This is what we call it systolic heart failure, what we used to call it before forward heart failure, or hypoperfusion heart failure, or low cardiac output heart failure, or low ejection fraction heart failure, as the latest definition, heart failure with reduced ejection fraction. So when the ejection fraction, the amount of the blood which is ejected with each systole, the difference between the end diastolic volume minus the end systolic volume divided by the end diastolic volume times 100, this is the ejection fraction. And the other type, which is with maintained systolic function, but the diastolic function of the heart is impaired. Like the diastole, in diastole, the heart has to relax to receive the blood coming from the atria, and the atria relax to receive the blood coming from pulmonary circulation, pulmonary veins when you're talking about left atrium, and IVC, superior vena cava, when you're talking about the right atrium. If the heart failed to relax and to give a room for the blood coming back to the chambers, then we call this diastolic heart failure, or we used to call it before, a couple of years back, a backward heart failure or congestion heart failure. Both of them can present with the same sign and symptoms at the end of the day, but it's a very, very important to differentiate if this is systolic heart failure with reduced ejection fraction or with preserved ejection fraction, or what we call a diastolic heart failure. There is very recently also another subdivision of heart failure, of group of heart failure patients, when the ejection fraction is not that impaired, but not less than 40%, and it's not above 50%, between 40 to 49% ejection fraction. We call it mid-range ejection fraction. So heart failure, HF, MR ejection fraction, mid-range, between 40 to 49 ejection fraction. And the percentage in the literature usually is between 50% here and 50% there. There is no solid data about this. Etiologies are very variable. When you're talking about reduced ejection fraction or reduced systolic function, the most common reason for this is usually ischemic heart disease, MI, arrhythmias. But when the ejection fraction is preserved or the diastolic function of the heart is impaired, this is most likely, the most likely reason for this is hypertension, valvular heart disease, and commonly associated with AF from the arrhythmia. Comorbidities are there in both types, but it's more common when it's obesity, obstructive sleep apnea, hypertension, as I mentioned, diabetes, anemia, renal disease. You find this comorbidities more toward the diastolic heart failure more than the reduced ejection fraction heart failure. Also, it's encountered in the literature to see a link between hyperglycemia, hyperinsulinemia, insulin resistance, cardiac stiffness, fibrosis, and many other things that result in impairment of cardiac systole and diastole. Hypertensive heart failure per se is very important to know that if you control the blood pressure, you reverse totally the diastolic dysfunction or heart failure. So it's very reversible. And this carries a message to everybody working in ICU. And I'm going to touch tonight everything related to the ICU point of view, because I'm not a cardiologist, but I'm dealing with the heart in ICU every single moment in different indications. As we used to say, the most common reason for respiratory system to fail is cardiovascular failure. And the most common reason for the cardiovascular failure to fail is respiratory failure. Kidney, when it fails, it affects the heart. Heart, when it fails, it affects the kidney. So we in ICU have to know details about the heart, and that's why we should not allow hypertension in ICU, particularly during the weaning time and many other situations. The pathophysiologically, the consequences to acute heart failure or acute heart decompensation is that you're going to see a lot of neurohormonal changes happens immediately with the heart failure. And we see this very frequently in ICU. Like you see sympathetic overactivity. How many times you round on your patients in ICU and you see them tachycardic? This tachycardia, one of the differential diagnoses that sometimes it's underestimated, is presence of heart failure due to sympathetic overactivity when the cardiac output reduces. So, and also renin, angiotensin, aldosterone release with arginine, vasopressin disturbances, all of this will result in tachycardia, very high systemic vascular resistance, sodium and water retention. This, at the end of the day, will result in ventricular remodeling of both ventricles and organ dysfunction. And this is the danger of that. There is what we call it, and you'll probably see this term in the reviews coming from intensivists, a congestion cascade. When the heart fails, there are many types of congestion or engorgement of the circulation. Number one, a hemodynamic congestion. When you're going to have increasing cardiac and venous filling pressures. This will result in pulmonary edema, of course, but also the congested vessels and congested ventricles wouldn't contract, ventricles per se wouldn't contract freely when it's congested. And we mentioned this in previous presentations several times, that we have to understand the physiology very well of Frank-Starling curve. The Frank-Starling referred to that the myocardium, as in general rule of any skeletal muscles, will contract more as you increase its preload or the loading condition of this muscle. As much as you're increasing the load or the preload for the left ventricle and right ventricle, either this preload is volume or pressure, the more you increase, the more you allow the muscles of the heart to stretch out. But you're going to reach a maximum point when the ventricle or muscles wouldn't stretch more. And here you stop to have increasing cardiac output. If the ventricles are congested, the cardiac output eventually will reduce because the muscle will stop to contract more. Number two congestion, which is organ congestion, and the most commonly here and most disastrous one, is the congestion happens at the level of the lung. And here you're going to see the pulmonary edema. But when the other organs congest, you start to see renal impairment, hepatic impairment, and eventually you're going to see edema everywhere, peripherally, neck veins, and many others. This congestion, if it's in the left side, you're going to see symptoms related to respiratory system, dyspnea, paroxysmal nocturnal dyspnea, intolerance to any physical activities, syncope, palpitation, feeling tiredness, fatigability, chest pain. But when the right side congestion happens, patients will start to complain of abdominal pain, nausea, vomiting, hepatojugular reflux will be very manifest, and you see engorged neck veins, and you see lower limb edema, and right mainly pleural effusion, but left pleural effusion also can happen. We have to be aware very, very cautiously about the signs of hypoperfusion in any patients with acute heart failure, because once you see the signs of hypoperfusion, you would immediately notice that this patient would have both types of heart failure, and not only systolic and not only diastolic. And the danger here is when you started to see hypoperfusion signs and symptoms, this will indicate that the cardiac output is impaired, and this ventricle or this heart requires to be supported with inotropes. We all know the signs of hypoperfusion, starting from hypotension, obtundation at the level of the brain. You see a lot of evidence of hypoperfusion. Decreased urine output, capillary refill impairment, cold extremity, increase in lactate, decrease in central venous oxygen saturation, and increase in end-tidal PCO2 are found to be very specific and sensitive in acute heart failure. There are many conditions which comes with heart failure, and sometimes it's overwhelming our thinking when we see these things and we underestimate that there is underlying heart failure that need to be dealt with to treat the serious event that engaged or make your mind very busy stressing on and focusing on. Like you have heart failure and patient is also shocked. This is, by the way, we don't call it only cardiogenic shock. Yeah, it might be pure cardiogenic shock with heart failure. Because as we mentioned in the definition, any heart failure, when it reaches the stage of hypoperfusion and impairment of the cardiac output, this patient by definition is in cardiogenic shock. And any cardiogenic shock is by default is in heart failure, definitely. But also respiratory insufficiency due to heart failure or a reason for the heart to fail has to be in mind, and one of the serious conditions that can come together. Also, myocardial ischemia per se is a typical entity for a great attention, but when it's accompanied by heart failure, it makes us more worried, and it warrants a more focus or attention. When you have arrhythmia, EF, ventricular tachycardia, bigeminy, trigeminy, whatever it is, it makes the scenario more worse. What I'm focusing on this, that we have to, in ICU, to be very vigilant, dealing with everything at the same time. We'll not focus on something and we'll forget many other things. There are indicators of advanced heart failure that when you see them, you have to know, especially preoperatively, while you're managing to prepare your patient for surgery or something, anesthesia, then a class, New York Heart Association class of 3 or 4 are very advanced indicator of advanced heart failure. When the ejection fraction is the less than 40%, more or less, more severe. When you have arrhythmia, hyponatremia, renal impairment, increased need for diuretic doses, and weight loss, these are signs and indicators of bad heart failure actually that warrant more attention. ICU admit a subset of heart failure that is severe heart failure. As I mentioned, when heart failure is accompanied by cardiogenic shock, arrhythmia, organ failure, respiratory failure, difficult to wean. And I'm going to show scenarios of heart failure patients presenting in ICU in daily practicing, how this manifests in ICU later on. But we see here that the cardiogenic shock associating a decompensated heart failure was found in different literature review and different surveys to range in different studies between 16 to 25%. Around 25% of patients with heart failure in some of the literature present to ICU in cardiogenic shock. And this is very, very serious. Not only that, but also organ dysfunction. How many times we see heart failure, and the main reason for the kidney to fail is the heart failure. The main reason to see ischemic hepatitis or fulminant hepatitis is that the heart is failing and the back pressure to the hepatic circulation and venous congestion caused, and also ischemia because of low cardiac output causes hepatitis, which sometimes very fulminant. Mortality, ladies and gentlemen, is considered to be very high in heart failure. It reaches in some of the literature up to 25 to 50% of patients with decompensated heart failure, they might die. And this is very high percentage, by the way. How we diagnose heart failure in ICU? We rely on many things. What we're going to focus today is that we should not forget simple things to expect or predict diagnosis, like history of patients with hypertension, obesity, obstructive sleep apnea, COPD, previous ischemic heart disease, previous echo with low ejection fraction, previous admissions with decompensated heart failure. This makes a lot in differential diagnosis. And clinical presentation. And as I mentioned, in ICU, we don't see patients with paroxysmal nocturnal dyspnea or orthopnea. We see them when they are in respiratory failure, multi-organ failure, cardiogenic shock, as I mentioned before. We should not forget that lab is essential in diagnosis and prognostication of acute heart failure. Echocardiography, as Dr. Walid mentioned in my presentation, that echo is a mandatory in dealing with diagnosing and managing any patient with heart failure. How would you know heart failure if you don't have echo? Investigations as the routine one, cardiac enzymes, electrolytes, and kidney function, hepatic, these are all very important. But you have not to forget the lactate, because the lactate is one of the very important laboratory sign of global hypoperfusion. So if you see high lactate, this is very, very indicator of bad function of the heart and worsening systolic function of the heart or low cardiac output state. This is very important. Not only that, but also ProBNP can be used to diagnose patients with acute decompensated heart failure in emergency situation. It's very sensitive. When the ProBNP in cases which is confusing to be heart failure or not to be heart failure, when the ProBNP is less than 100 picogram per ml, this is against acute decompensated heart failure. Once you see the ProBNP is higher than 100, this is indicate a dilation of both atria and ventricles, and it's a good indicator of heart failure, especially in intensive care patients who are ready to wean, but then you question their cardiac function. ProBNP can be very sensitive to give an indicator of good versus bad cardiac function. Plus, of course, as I mentioned, essentially the echocardiography examination. Of course, ECG can help. Radiologically, chest X-ray and lung ultrasound is considered also to be a very essential part, and it's there in every recommendation and guidelines. Let's start by this radiologic investigation, chest X-ray versus lung ultrasonography. You need a modality to see the lung in any acute heart failure patients. Why? To diagnose pulmonary edema, to differentiate if this is cardiogenic or non-cardiogenic, and to see that there are some, if not many, cases that can come combined together, combined with cardiogenic and non-cardiogenic heart failure patients who is presenting as well with pneumonia or COPD exacerbation or many other things. So combined cases are considered to be not infrequent in critically ill patients. Also, you would see if you have pleural effusion. If I ask the question, chest X-ray or lung ultrasonography, the answer comes from a many big body of literature to support that lung ultrasonography is considered to be more sensitive and more specific with good predictive values compared to chest X-ray. And chest X-ray is totally insensitive and inspecific when it's compared to the gold standard, which is CT. Just lung ultrasonography is coming to be on the coming few years, if not few weeks or months, is coming to be as gold standard as the lung CT. Why? Because you can see everything that you would see with CT, you can see it with the lung ultrasonography. Particularly, there are many investigations or research on comparing chest X-ray to lung ultrasonography, and lung ultrasonography was found to be superior in predicting the pulmonary edema. Look at this chest X-ray of a real life cases, which I had. This patient presented with respiratory failure, signs and symptoms, and he was desaturating. Look at the chest X-ray. Would you see anything suggestive of pulmonary edema here? The answer, I think you would agree with me that there is no indication of batwing congestion, hilar congestion, parahilar congestion, or careless lines, or dilated cardiomyopathy, or dilated heart, or cardiomegaly. But look, when we have the ultrasound exam bilaterally, you would see here what we call it extensive B lines, a vertical line, comet tail, starting from the pleura, ending by the bottom of the screen with erasing the A lines. This is typical criteria of B line. And when you see B line bilaterally like this, with looking healthy, shiny, smooth, not dirty, pleural line, you call this a confluent B line for a cardiogenic pulmonary edema, especially when you see them diffusely distributed evenly bilaterally in both lungs, dunes, you would say that this is cardiogenic pulmonary edema. On the other hand, when you see this chest X-ray, you wouldn't at all, in this patient who presented with hypoxia, and he was showing all signs and symptoms of sepsis. Feverish, white cell count is high, and the lung X-ray is typically showing a careless line here, cardiomegaly, batwing congestion, bilaterally with redistribution into the from center to periphery. Typical for cardiogenic pulmonary edema on chest X-ray. When we do the lung ultrasonography, you will see clearly here that the left ventricle is badly contracting. The right ventricle is not that bad, but there is left atrial dilation here, indicating systolic and diastolic dysfunction. At the same time, when you look at the lung ultrasonography, you see part of the pleura is healthy, while the other part is corrugated, thickened, and adhesed with extensive B lines as well. This wouldn't be typically for cardiogenic pure pulmonary edema, but would be matching with a cardiogenic and non-cardiogenic as well. Look at here, this is the spleen, and this is the left lower lobe. It's totally consolidated with, you see here, a lot of white dots that does not disappear when inhalation happens, indicating collapse, and some of these white dots are dynamic that disappear with inhalation, indicating with these B lines that we have a wet lung consolidation in this weak left ventricle with systolic and diastolic dysfunction, so combined cardiogenic and non-cardiogenic, with no lung ultrasonography, with relying on plain X-ray, you wouldn't be able to differentiate between cardiogenic and non-cardiogenic pulmonary edema. Lung ultrasonography is also very helpful in prognostication of acute heart failure. That studies, a lot of studies in the literature, and some of them are very recent, that the more you see B lines at time of discharge from ICU or from the ward or from hospital home, the more you leave your patients with wet lung, the more you're going to have a higher rate of readmission and higher even mortality. And from this, patients has to be drying more than what we believe to be. Echocardiography is among 1A, 1C recommendation in every guidelines, European and American. Echocardiography is considered to be mandatory for every patient whom you suspect in ICU or outside of ICU that they have heart failure. You have to have echocardiography examination to define subjectively via using your eyeballing, or objectively when you have measurements that this patient has heart failure or doesn't have heart failure. And this heart failure is systolic heart failure or diastolic heart failure, because the management is totally different, as I'm going to show you later on. Let's go with the journey of heart failure. How can we use the echo to help quantifying and diagnosing acute heart failure? The first and very simple way to use is to use your eye to comment on the left ventricle and right ventricle, and to comment in systolic function mainly. Is this patient's left ventricle is contracting normally, as you would see here in this loop of heart, that you see the endocardium thicken with every systole, and the size of the left ventricle reduces significantly. Both of these signs are more than 30% thickening increase of the endocardium of the left ventricle muscles, and decrease by more than 30% of the size of the left ventricle with each systole. This indicates normal systolic function. On the other hand, if you look at this left ventricle, you wouldn't have much effort to see that the size of the left ventricle here doesn't reduce much with each systole. And if you look at the septum here, you wouldn't notice at all any change in the size of the muscle with contractility, but you would see some change of the lateral wall of the left ventricle. So I will diagnose here that this patient has systolic, by eyeballing, systolic dysfunction, and I would say that this might be mild, moderate, or severe left ventricle dysfunction, or ejection fraction less than 40% or more than 50%, or between 40 and 50%. This is by eyeballing. How much you need as an effort to say that this patient's left ventricle here is dilated, as you see, not reducing in size, as you see here with the system, and the thickness of the muscle globally doesn't change much. So I wouldn't have any difficulty to say that this patient has severe cardiomyopathy or hypokinesia, global severe hypokinesia. So, and this patient ejection fraction is far away less than 40%. You might say that it's less than 20%. So there is no effort here. Look at this short axis, parasternal short axis. This is the left ventricle. This is the RVOT. This is the septum. You can see that the left ventricle is just flickering in movement with each systole. While on the other hand, you would see that the left ventricle is hyperkinetic and hyperdynamic, and the papillary muscles here are kissing. So this ventricle, by eyeballing, is on the extreme of the normality, which is hyperdynamic, globally hyperdynamic left ventricle. We should not forget, and this is very important, and I would stress one of the very straightforward messages from tonight, that not every septic patient should have hyperdynamic left ventricle. This is an example of a young gentleman, around 27-year-old, who presented to us with septic shock, and after 3 or 4 days, the left ventricle turned to be from hyperdynamic to, as you see here, very hypodynamic. So what we call it septic cardiomyopathy. And this is if you have evidence of low perfusion on these patients who were septic, is now in cardiogenic shock or in heart failure. And if you measure the filling pressure of this left ventricle here, you would see it very high, because every systolic dysfunction is going to end by diastolic dysfunction, and every diastolic dysfunction is going to end by a systolic dysfunction. Diastolic dysfunction would be very well expected when you see a hypertrophic concentric left ventricle hypertrophy, and this doesn't need much expert eyes to identify. Look at this is the left ventricle, and this is the circumferentially the left ventricle muscle in short axis view. See, it's globally hyperkinetic and globally thickened, and this is what we call it left ventricle hypertrophy due to long-standing hypertension. Of course, there are some differential diagnosis has to be in mind, like amyloidosis and many other infiltrative heart disease. But if I have history of hypertension, this patient, I would expect hypertensive with left ventricle hypertrophy to have sort of diastolic dysfunction, as we're going to show later on. Also, you might see good systolic function, but with biatria dilation, as you see here, this patient would definitely has a high filling pressure, hypopulmonary capillary wedge pressure, and pulmonary edema, especially at the time of weaning from mechanical ventilation. So quantitative measurement using the eyeballing was found to be very simple, and it avoids the individual variation, because you and me can agree that this is mild dyskinesia or mild global hypokinesia, and this is moderate, this is severe. The ejection fraction numbers doesn't matter. At the end of the day, bedside, I would say that this patient has a severe systolic dysfunction or moderate dysfunction or mild dysfunction. This needs inotrope, this doesn't need inotropes, and so on. There is evidence supporting this, that when we go with qualitative rather than quantitative, you do well, and accuracy was tested very well with evidence that there was no big differences between the eyeballing and the quantitative measurements. But sometimes you need quantitative measurements to measure the cardiac output, and this is very easy in this parasternal long axis when you have the M mode, and then you can measure the ejection fraction and fraction of shortening, and this is, both of them can be a reflector of systolic function, but ejection fraction doesn't equal cardiac output, because ejection fraction is a regional systolic function assessment where you put the line and here you estimate the ejection fraction. Simpson can be better, but there are a lot of drawbacks of Simpson, that you have to have a very good orientation of the endocardium all over during the systole and diastole, which can be a little bit difficult job in ICU patients. You can measure the cardiac output when you measure the left ventricle outlet tract area in the long axis, as you see here. You freeze and you measure during the systole. You can have the area. When you have the 5-chamber view and you put the pulsed wave Doppler in the LVOT area away from the aortic valve, then you're going to have the VTI, velocity time integral, through the left ventricle outlet tract, and then you outline the area under the curve. It gives you the VTI. You times the VTI by surface area of the LVOT, it gives you the stroke volume, and then you can times this by heart rate, it gives you the cardiac output. The machine can do everything for you automatically, as you see in this example. You can measure the cardiac output very non-invasively and very simply bedside, and it doesn't take time if you have good views. The cardiac output of the RV also should not be forgotten and should be measured, because as you have the left ventricle failure, you might have the right ventricle failure, and the same physiologic application is there. TAPSE and MAPSE, the annual excursion of both tricuspid and mitral valve, are good indicator of systolic function of both RV and LV. Diastolic function can be easily estimated when you have the mitral inflow with pulsed wave and you measure the E wave at the earliest diastole and you measure the A wave at late diastole before the systole, and this is IE, E to A ratio. And when you use tissue Doppler, you can have E to E prime when you put the tissue Doppler and the pulsed wave as the annulus of both lateral and medial mitral valve leaflet annulus, and then you take average of E to E prime. This is very well good studied predictor of pulmonary capillary wedge pressure, that it will be very high, indicates high filling pressure of the left ventricle and cardiogenic pulmonary edema due to diastolic dysfunction. Of course, we use the tricuspid regurg jet to quantify the severity of diastolic dysfunction as well as the left atrial volume. Management, ladies and gentlemen, has to be both diagnosis and treatment has to be hand in hand. You should not delay doing the necessary action to manage patients, waiting to diagnose the heart failure or to do the echo or repeat the echo. But once you diagnose heart failure, you have to go with management, triaging them, categorizing them, those who have advanced heart failure and with severity that necessitate admission to ICU when they are in respiratory failure, cardiogenic shock, or multi-organ failure, immediately admit to ICU. And as per evidence of heart failure alone, or heart failure low cardiac output alone, or low cardiac output with filling pressures high, you have to deal with both. You have warm and dry patients, means they are perfused and they are not wet yet. So they are in heart failure, but still there is good perfusion, there is good filling pressures. But you might have patients with hypoperfusion and they are still dry. They are not in pulmonary edema. This is cardiogenic shock patients. They are hypoperfused. They might be warm and wet, perfused, but they are congested or in pulmonary edema. They might be cold and wet. Cardiogenic shock will be hypoperfused and cold, and all cardiogenic shock are in pulmonary edema by default. And this has to be in mind when we managing patients. Wet and dry, pulmonary and organ edema, then you have to use fluid removal by diuresis, by CRRT, and then you have to use cautiously vasodilators, and you have to consider mechanical ventilation, anti-failure medication, including ACE inhibitors and beta blockers. Spironolactone has to be all in the package of managing acute heart failure with evidence that they are congested. If they have evidence that they have perfusion issues, then you have to think of using inotropes. And don't leave your patient's heart suffering and you are underestimating that this patient's heart need inotropic support, dobutamine, levosimendan, or any melarinon or any other sort of inotropic support should be indicated when you have evidence of low cardiac output, and this should not be delayed and should not be forgotten at all. That's why, again, this is one of the great messages that you have to see anatomically and functionally. How is the left ventricle and right ventricle working, systole and diastole? Because this will give you a clue when to start and when not to start inotropic support. If you use inotropic support unnecessarily, because some of our colleagues, they go empirically and randomly and blindly, and they start dobutamine for every patient in heart failure in ICU. And this is dangerous because this was associated in the literature as one of this literature supporting this, that it's associated with non-morbidity and mortality. You have to have evidence of low cardiac output, either invasive or non-invasive. And the golden for non-invasive measurement of the cardiac output is the echo, as I mentioned before. There are many other modalities like ECMO, CABG, BCI, case by case, individual case, but you shouldn't stop. You shouldn't stop to refer patients for ECMO, central ECMO, VA, and you might save patients, especially in postpartum, in post myocarditis, viral myocarditis, they're salvageable. They can survive and they can make it. Let me end my presentation by a few examples of daily scenarios that we are facing in ICU. How many times, ladies and gentlemen, you have patients admitted to ICU with acute on top of chronic respiratory failure, like my patient here. And the differential diagnosis of any acute on top of chronic respiratory failure in COPD patients, when they come with type 2 on top of chronic type 2, with BCO2 very high, BH is low, bicarb is high. And then the differential diagnosis includes infection, bronchospasm, pneumothorax, electrolyte, muscle weakness, and heart failure and pneumothorax. Here, look at this patient who stayed 2 days on non-invasive ventilation, treated with antibiotics and treated with bronchodilators and everything possible to bring him out of acute of chronic respiratory failure with no benefit, because nobody cared to put a probe and see how is the left ventricle. Look at this left ventricle of this patient. There is no good systolic function here. The left ventricle is badly contracting. This is the long axis, and this is the short axis. And look at the apical 4. Also, you can see obvious mitral regurg. So this patient had, and this is the ejection fraction. It's around only maybe 30%. And this is the, what we call it ASPP, the distance between the A wave and the septum in diastole. And it indicates when it's more than 1 centimeter, bad systolic function. And the diastolic function with tissue Doppler was showing E to E prime 32. This is the average, this is the lateral, and this is the medial. Average is above, far away above 20. So very high pulmonary capillary wedge pressure. And this patient needed heart failure management. And once we started the anti-failure medications, everything improved within 24 hours and patient discharged from ICU. Without echo, you wouldn't diagnose heart failure. You wouldn't see that this patient, any patient with respiratory failure, should warrant a diagnostic echocardiography examination immediately after admission to ICU. At any convenient time, immediately after ICU admission. And also look at this patient who was in ICU. I rounded on him. I found him very tachycardic, as you see here in the bedside monitor, 143. But he is comfortably breathing with a pressure support, breathing 18, saturation is 99%. But this patient is on positive pressure ventilation, persistently, in spite of big doses of beta blocker and big doses of calcium channel blocker. And this is another very straightforward messages, that beta blocker and calcium channel blocker should not be used blindly, especially in old age patients. Look at this patient, left ventricle, and please comment on this. How would you comment by eyeballing on this left ventricle? This patient was on 10 milligram of propran, Concord, 10 milligram. And he was on calcium channel, diltiazem. And all this was what we tried to control the heart rate, which remained 140 or more. This patient doesn't need beta blocker. He is in heart failure. And this ventricle cannot tolerate negative enotropicity of both calcium channel blocker and even very selective beta blocker. Wouldn't tolerate. And what this patient needed actually is to improve the systolic function, is to come up with a medication that helps the systolic function of the left ventricle. And at the same time, you decongest him to allow the left ventricle to contract better. We started the digoxin and we give him anti-failure medication and we stop beta blocker. Look at the heart rate after 24 hours of management. It came very significantly down and patient was weaned from mechanical ventilator. I'm not saying that we are doing magic job, but this is what the job has to be done in ICU actually. We are not creating the wheels, but we have everybody working bedside in ICU has to bear in mind that it's not luxurious to look at any patients, especially those with any history or suggestions of having cardiac dysfunction, to have echo examination for them. And it's not luxurious, it's mandatory for everybody working in ICU to have basic echo evaluation ability, because this is mandatory. And what I'm saying is not what I say, but it's the words of recommendations and guideline everywhere in the literature. You can see that the drugs can be still in the recommendations as to be recommendations. In European and American, they don't go much with the Juxin, but it's not a bad drug to use when it's indicated to be used. Difficult to wean is a common daily scenarios in ICU. And one of the common reasons for your patients to fail weaning from mechanical ventilation is presence of heart failure. How can you wean somebody with this severe mitral regurg? You have to control this regurg. You have to control the systolic function. You have to improve the cardiac output before you attempt to wean patients from mechanical ventilation, as we mentioned in details in the presentation of weaning from mechanical ventilation. To sum up, and I'm so sorry for being a bit late, but acute heart failure is a very frequent cardiac ICU and in general ICU, very encountered problem in ICU. We have to be aware of typical and atypical presentations of heart failure in ICU. Consider to put in the differential diagnosis of any acute type of chronic respiratory failure, or any patient with respiratory failure that the respiratory failure is due to cardiac failure. And please consider to put in the differential diagnosis of any tachycardic patients, not only fever or sepsis or anxiety or pain, but it might be due to heart failure. And also, lung ultrasonography is found to be very far away better than chest X-ray. And we have to pass the borders of having daily routine chest X-rays in ICU, but to have daily routine lung ultrasonography. And we have to practice this. Echo is mandatory, ladies and gentlemen, and we should not underestimate this. Use the needed therapy while you see what's going on functionally and anatomically before you decide the way of management. And this cannot be done without echo examination. Thank you very much.
Perfect. Thanks very much, Dr. Ashraf Tayar, for this fruitful presentation as usual. So the first question here, I know you're supporting much or you're going against the static parameters to the dynamic parameters, but the question here is, could you please explain how to measure the pulmonary capillary wedge pressure using echocardiography? You can stop your presentation, Dr. Ashraf, if you wish.
Okay. There are a lot of evidence on using E to A prime and E to A ratio for filling the pressure of the left ventricle. As far as you go above E to A prime, above 14, the more is the pulmonary capillary wedge to be above 18. Of course, you have to have in mind the limitations of this. It's sometimes very difficult to have tissue Doppler examination, but if you see tricuspid regurg and jet is above 3, tricuspid regurg jet, if you see a biatrial dilation and with every systolic function by eyeballing, you would expect that there is a bad diastolic dysfunction. The surrogate of diastolic function is the filling pressure of the left ventricle, which is the pulmonary capillary wedge pressure.
Perfect. So this is the first question, and the second question is how to differentiate between ARDS and cardiogenic. So what's the difference between cardiogenic and non-cardiogenic pulmonary edema if we're using the echo?
Okay, great. In very simple way, when you have pulmonary edema, you have extensive B lines bilaterally. When you have extensive B lines bilaterally, look at some other points. Number one, you start with a pleural line. If the pleural line is shiny and the B lines moves with the pleural line very smoothly, and these B lines are confluent, equally distributed bilaterally in patients with history of heart disease or history of presentation or presenting with sign or symptom of heart disease with no signs of diseased pleura, this is cardiogenic pulmonary edema. If you see confluent B lines with what looks like diseased pleura, adhesed pleura, thickened, corrugated pleura. This is a non-cardiogenic pulmonary edema. And you would see that they are unevenly distributed. So you see it patchy, bilateral. So you see it on the right side, on the mid-axillary line. When you go to the left mid-axillary, you wouldn't see it. If you are in the same lung, you might see spared area. So you see it in the mid-axillary line. When you slide the probe up or down to another intercostal space, you might see area of no B lines at all. Or you might see B lines here, and then you see consolidation signs beside or far from this area. So patchy distribution, uneven, haphazard distribution of abnormalities matching with ERDS, not with cardiogenic pulmonary. Of course, this has to be put in the context of presentation, history, physical, and laboratory. So patient presenting with fever, young age, sign and symptom of pneumonia, and you see confluent B lines, dirty pleura, then this is straightforward ERDS. But the message again, that not every patient who is septic is having septic cardiac function, hyperdynamic cardiac function, or normodynamic cardiac function. They might be septic, but they have cardiogenic abnormalities, or what we call it septic cardiomyopathy, which is encountered in around 50 to 60% of cases. 50 to 60% of septic patients, they need inotropic support because of low cardiac output. People, they still believe that every septic patient, especially in the area of corona, they still believe that every shock patients who are septic, they are septic shock. They might be cardiogenic shock in septic patients.
Perfect. I think the message is clear. Professor Ahmad Madi is one of our talent speakers, and he has a question here. How much will you dry your patient with heart failure during the weaning process? And is there any role of ultrasound and echo during this drying process?
A very, very good question. And there are a lot of research on this, Dr. Ahmed. If you just write on anywhere in any PubMed or anything, just write heart and lung and weaning, you're going to see a gush of literature to support evidence saying that a dry lung is far away better than wet lung in weaning. So people, they go with cardiac output measurement with E to E prime, E to A ratio to have evidence of filling pressure that are under control. The time of a spontaneous breathing trial is very stressful for the heart. And there is what we call it weaning-induced pulmonary edema, which is very frequent, a reason for heart failure. So what to do? Number one, lung ultrasound examination, especially in the mid-axillary and posterior axillary line for looking for B lines bilateral, number one. Number two, go to the heart and see the systolic function, cardiac output, measure the cardiac output, and you have to have VTI near to normal, 15 or more. And then E to E prime, less than 14 if you can. And some people, they might say reach up to 18, the average, not the median, not the lateral. And as far as the E to A ratio is less than 8 and more than 0.8, you are in the safe context. So you can use all effort, including the vasodilators, after load-reducing agents, inotropic support even, nitroglycerin, morphine during the weaning to reduce the preload. All these measures, and consider to use non-invasive immediately post-extubation, especially in patients with history of cardiac diseases. They might fail immediately because of cardiac failure. These are the parameters that we use to go with.
One of the interesting articles I had read myself about the spontaneous breathing trial with ultrasound or echo guidance pre and post. So they do the EA ratio and EE prime pre the weaning trial, and once the weaning is started, like for 30 minutes or 1 hour, they do assess the EA ratio and EE prime and measure, and this is on its own is an indicator of failure versus success of the weaning trial. I'm sure that you had read this article as well, but it's very promising.
I personally do this every day in my patient before we wean. We do the echo assessment pre, during, and after the spontaneous breathing trial. And if we see evidence that the patient will not tolerate, either you go with non-invasive immediately or you delay the extubation. I have patients currently whom I'm dialyzing every day to bring down the congestion parameters to the minimum as we could. And mitral regurg is very common, by the way, and very, very serious to disturb the weaning process.
Perfect. So we have loads of questions, Dr. Ashraf, but unfortunately, it's an hour from the start of our webinar. So I think we stop questions here. Thanks very much. And we do really appreciate your share with us tonight. And we are proceeding to the next lecture